No one wants to be considered by their doctor as a number. However, today I want to convince you that clinicians routinely assess their patients in numbers and that this is a very helpful and useful thing. And I want to illustrate how my research contributes to this practice. So to do that, I would like to take you on an imaginary consultation with a doctor, let's say your GP. So imagine yourself sitting in his office, and what's going to happen? First, you'll describe your complaints, right? And then the GP will probably answer by asking you additional questions. Can you say more about your complaints? When do they occur exactly? Are there any alleviating circumstances that make your complaints go away? So far we're not talking about numbers. But in the next phase, your GP may decide to do some physical examination. For instance, you're suffering from a certain pain and he will inspect this specific body part or maybe use an instrument to inspect your ears, but still no numbers. Now we get to a phase which is a bit different. He may decide to do additional examinations, either himself or maybe he'll ask you to go for additional blood work or have an X-ray photo taken. When this happens, it becomes a bit different. The first numbers start coming in. Let's say the GP takes your blood pressure and it's 120/75. And he says, well, that's perfect, very nice. And he goes on and takes your temperature. Your temperature is 39 degrees centigrade. Well, you all know that's a high fever, that's not good. So here we have a first number actually describing your physical circumstances, telling something about you and your body. And you all know that 37 degrees centigrade is a good temperature for your body. And if it rises, so becomes over 38 or even 39, it's bad. So here we have a number that we can not only use to determine that something is abnormal, but we can also use it to monitor disease progression. Because if your temperature becomes lower, we know that you're getting better. Okay, so I'm not telling you anything new, right? You know this about temperature. But how do we actually know that 37 degrees is a normal body temperature? Well, you're all scientists. So you know that to determine a normal value, you have to measure it in a lot of people, in a large representative group. So in this case, you will measure it in a large group of healthy people, which would give you a normal distribution. And you also would assess it in patients to see what the range of total values could be. Now, this is a simple measure, right? Temperature is just a single number. And also, if you would take blood work, you would also get single numbers. Let's say your glucose level or your cholesterol level. So that's still rather simple. But what if we're talking about this X-ray photo that also could have been taken? Now it's not so simple anymore. One difference is also that X-rays are not only used to determine whether something is abnormal, but also what is abnormal. So we also want to use it to get to a diagnosis. And normally, routinely, doctors look at X-ray photos. They've learned over the years by practice to recognize certain patterns in those photos that indicate what is wrong on the photo. Now, actually, photos consist of numbers, basically arrays of numbers. An X-ray photo is a black and white picture. And every pixel in this photo is just a number between 0 and 255. 0 for a black pixel, 255 for a white pixel, and anything in between. So if we could teach computers to recognize patterns in these X-rays, like for pneumonia or a broken bone or for an object in your gut, then maybe they could help us determine what is wrong on such a photo. To do this, in principle, we could use mathematics. And why mathematics? Well, as I said, the X-ray photo consists of numbers, and mathematics is simply a number crunching tool. All right, so in the past minutes, I took you from a simple single measurement to a rather complex measurement, an X-ray photo, but it can be more complex. What if you came to your GP because you suffered from a strange seizure, and your GP decides to send you to a neurologist, and then he determines that you need an EEG, an electroencephalogram, measuring your brain function. Now, many more numbers come in, because what happens in a routine EEG, we measure your brain function from about 20 electrodes during 30 minutes at about 250 hertz. So let's do the math. That's 20 electrodes, 30 minutes, 60 seconds, times 250 hertz, that's 9 million numbers. So now we have a lot of numbers. And actually, routinely, clinicians look at the EEG to determine what is wrong. So again, they have years of practice to learn to see what's going on in an EEG. But you can imagine that also here, mathematics and computer analysis can help to get more out of the data, to recognize patterns that are not so obvious to the human eye. And that is the field of research that I'm working in. It's just an example. But by now, I think you get an idea already of why patients in numbers are interesting and why it could be useful. And if you think about it, in the past decades, many more machines have become available that can assess you when you're ill. And those machines have become more and more complex over the decades and also yield more and more numbers. So many that it's not always possible anymore to just look at the results. But we do need computers and mathematical analysis to get something useful out of that. Meaning, we want to know about diagnosis, we want to monitor disease progression and other applications. So here, mathematics is useful. And I want to illustrate by some examples how my research contributes to this field. So let me start by a somewhat older example, which is a bit alike to the X-ray photo example. In our department, we routinely use ultrasound imaging to assess muscles. And you may know ultrasound from the prenatal examination in fetuses. So ultrasound imaging also yields a black and white image. And why would it be interesting to use that in muscle assessments? Well, first of all, a muscle looks different on an ultrasound image when it is diseased. And second, ultrasound imaging is a very patient-friendly technique. It's non-invasive, and it can also be used at the bedside, and we can use it in children. So it's easy to apply for clinical practice. Now, what does a muscle look like on an ultrasound image? If it's healthy, it's quite black. If it gets diseased because it's some neuromuscular disorder, it generally gets whiter on the image. And that can be either more homogeneously white or in a more patchy manner with all white areas in the image. Again, just like the X-ray photo, it's typically assessed visually. And clinicians use a rating scale for that. And a rating scale is a scale of numbers, in this case from 1 to 4, indicating what the image looks like. So in this case, 1 means a normal image, and 4 means an image that is completely white and to such an extent that the bone echo is no longer visible. Now you can imagine if you're using a scale like that, it's not highly accurate. So if you want to measure small changes over time, that's hard to do. And that could be interesting if you're interested in the effect of medication or in disease progression as such. So we thought, and not only us, but many other researchers, that by doing quantitative image analysis on these ultrasound images, you may be able to improve upon this, to make this assessment more reliable and more reproducible. So let me tell you a little bit about how that is done. As I said, these images consist of numbers. It's similar to the X-ray photo. So again, here we have values representing each of the pixels. So let's think first about how you can represent how white the image is. Well, that's not very difficult, right? If you take the average value of all the pixel values, that will give you a measure of how white it is. The lower the value, the blacker, the higher the value, the whiter the image is. Now, patchiness or inhomogeneity is a bit of a different story. You have to think about that more carefully. So I thought, what to me is the essence of patchiness? Just think about it. Well, you see white areas in a blacker image, like little islands, and you want to identify those. So what makes this island an island, it is that it stands out from the background, right? Now, standing out from the background basically means that we have two adjacent pixels that differ a lot in value. So one is white, the other one is black, and they're next to each other. Mathematically, this means that there is a large gradient. So what I did is I used a specific filter that identifies these large gradients in the image. What you then get is a new image, but now white pixels in this image indicate the boundaries of these white areas, and the black pixels indicate more homogeneous areas in the image. So if you start counting the white pixels and relate that number to the total number of pixels in your image, you get a measure of patchiness. So now we have two values describing how white the image is and how homogeneous it is, how many patches we have. And we had to show that that was indeed useful for clinical practice. So what we did is we showed that by using just these two numbers, we can distinguish between different neuromuscular disorders. So this is an example of how mathematical analysis can show you something about the diagnosis of these neuromuscular disorders. So I hope by now you're starting to be convinced a little bit that expressing patients in numbers can be useful. But I want to make my case even stronger. So let's go to another example. So the muscle ultrasound example was about measuring someone and quantifying what you've measured. We did something similar, and with we, I mean Octavio Martinez, who is a postdoc in my group, and myself, regarding movement. Over the past years, we've done several studies looking into that. Now, let me explain why it's interesting to quantify movement. First of all, in our department of neurology, movement disorder specialists always have to decide what movement disorder they are looking at. And sometimes it's hard to distinguish between them. So in some cases, Parkinson's disease may look like essential tremor. Furthermore, there are not always biomarkers available that allow you to make a diagnosis regarding movement disorders. So what clinicians do is use all the available evidence they have to make a distinction between these movement disorders. An important part of that is assessing a patient visually, looking at the movement of the patient. So what they would do is they have the patient walk, they raise their arms, they point at things, they do all kinds of movements that evoke the movement disorder or give more information about the movement disorder. Now, if you would just do this, that would not be very reproducible over assessors. So there have been many efforts to make rating scales for assessing these movements. So we also have rating scales for Parkinson's disease, for tremor, for ataxia, for different types of movement disorders. But it may not come as a surprise to you that similar to the muscle ultrasound rating scale, these scales are not perfect yet. Again, it's difficult to assess small changes over time, and reproducibility is quite high, but that really depends on the experience of the assessor. So if someone is less experienced, reproducibility is less high. So we thought that it would be useful to try and quantify the movements that are at the basis of these rating scales to help improve upon these problems. And today I want to speak about a specific example, about the distinction between early onset ataxia and developmental coordination disorder, or DCD, in young children. These diseases are very hard to distinguish by just looking at them. So, to assess ataxia, there's a specific rating scale. And one of the tests in this rating scale is the finger-to-nose test. And this test goes as follows. I need another finger, so that's the finger. And we ask the patient to move their finger from the nose to the finger of the assessor repeatedly, like this. Well, I'm quite okay doing that, but if you're a patient, it's not so easy. So we started by trying to assess that test. Now, to quantify this test is, of course, a completely different story than quantifying an ultrasound image. To begin with, this movement is not immediately expressed in numbers. But there are possibilities to express a movement in numbers, and they mostly involve movement sensors. And movement sensors are little devices that allow you to measure aspects of movement, like acceleration or a rotational velocity. And the good thing about them is that they're relatively small, allowing to pack them in small boxes, like this one. You probably already saw that I had one on my wrist. This is a shimmer. And this little box contains accelerometers, gyroscopes, and magnetometers. So it can measure acceleration, rotational velocity, and the Earth magnetic field all at the same time, continuously. And having these three measurements together allows us to do something interesting. We can use rather complex mathematics to derive the 3D trajectory of the movement over time. Now it becomes interesting. Knowing this, we used 3 of the sensors and put them on the ataxia patient's arm, on the upper arm, on the forearm, and on the finger doing the finger-to-nose movement. So what we then can do, again with complex mathematics, is derive the 3D trajectory of the fingertip over time in space. So now we've expressed this quite complicated movement into 3D coordinates over time, in a way already quantifying the movement. But these numbers by themselves are not very useful yet. it's similar to the ultrasound image again. Just having all the pixel values is not that telling yet. We need to do something with these measures before we can derive something useful from it. So we did something similar for the movement analysis. Let me remind you what we have to do with the finger-to-nose test is to determine whether someone suffers from ataxia or DCD. So we now have to think about what makes this movement ataxic, right? So remember the muscle ultrasound image, I thought about the patchiness. But that is not so easy, because if we knew what makes the movement ataxic specifically, then the doctors could also do it 100% certain all of the time. So it's more complex than that. It's not just a single thing about this movement that makes it ataxic, but it's a combination of things that makes it ataxic. So what we now did is we used these measures that we now have, the 3D coordinates over time, to derive different features of the movement. For instance, we know about the ataxic movement during the finger-to-nose measurement, that it's more irregular and that there's also loss of coordination. So for instance, there is undershoot or overshoot to the target. And we can translate these concepts into mathematical features of the movement. So now we have different features and we want to use those to make the distinction between ataxia and DCD. Now the mathematical procedure that can help you do this is called a classifier. And there are many classifiers around, many different properties. They have many different properties and their advantages and disadvantages. And the one that worked for us in this specific example is the random forest classifier. And what we did in this test is try to classify DCD patients, ataxia patients, and controls as a reference. And it allowed us to identify the ataxia patients and the controls about 80% of the time. Unfortunately, we could only identify the DCD patients about 30% of the time, random almost. So why is this? Well, we're just using one test at the moment, just the finger-to-nose test. So apparently that test is very telling already about whether it's ataxia or not and could be useful in the diagnostic procedure and in follow-up. But we need more of the tests, probably, to also distinguish DCD. So that will be our follow-up step. So I've given you two examples of projects in which we measured different aspects of movement. So it's time to wrap up now. I started by talking about simple measures that we can quantify, like temperature and blood pressure, for instance, that allow you to determine whether something is wrong and how bad it is. And then I showed you how research can contribute to determining measures of patients in numbers. I gave you the example of muscle ultrasound imaging, where just two simple numbers can help you distinguish between different neuromuscular disorders. I also used a more intricate example in which we used movement sensors and classifiers to make a distinction between movement disorders, and these can all be used also for follow-up. So I hope that by now I've convinced you that expressing patients in numbers is not a bad thing, but is actually very useful and helpful, and that we as researchers can help and contribute to this practice. Thank you.